Please listen carefully.
Hello, and welcome to GasGasGas. This is the best podcast for the FRCA Primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, and welcome to GasGasGas. We're cracking on with yet another episode in our joyful opiate-flavoured pharmacology jaunt of a chapter. Today we are doing heroin, or we should say doing diamorphine. First anecdote of this podcast is when I accidentally told a patient's father that I was going to give them heroin up their nose to make it easier to put their finger straight, because it was wonky. Error. The kid, as you might expect, was like, yeah, no, I'm on that. And the dad was like, oh, no, I don't know about that. And then I realised the error of my ways and the backtracking was challenging. So, first tip of the day, don't tell kids you're going to squirt heroin up their nose. Just say it's a nice painkiller. Righto. So, diamorphine is an opioid, everybody. And it's a synthetic diacetylated morphine derivative. Di, two acetylations. Acetylated, there are acetyl groups. How does it come? So it comes as a powder for reconstitution in a variety of quantities. It can be either 1 milligram, 5 or 10 milligrams in an ampule, depending on what's available. It can be administered intravenous, intramuscularly, intrathecally, epidurally, and intranasally. I'm sure there's a bunch of other routes as well. How does it work? Well, as we all well and know nowadays, that it works on G-protein coupled opiate receptors. The subunit on the inside of that cell is a GI protein inhibitory, and it triggers a number of mechanisms within that cell that leads to diminished transmission by way of hyperpolarizing that cell membrane. It does this by opening potassium channels, closing calcium channels, and inhibiting adenyl cyclase, leading to less cyclic AMP available. So, diamorphine, what do we use diamorphine for? Unsurprisingly, we use it for pain. It is a potent analgesic. However, when do we use this potent analgesic? So, it's certainly something that is sometimes reached for in the palliative care environment. Anaesthetists classically reach for this when delivering opiates to someone's CNS, i.e. epidural or intrathecal. Midwives in some hospitals are giving it IM for pain relief in labour. And, as you might expect, it behaves like morphine. So if someone has crashing pulmonary edema, left ventricular failure, we need to drop their preload and make their sensation of breathing better, you could use diamorphine, although more classically people do reach for morphine on the wards. Yes, so what is the dose of diamorphine? Well, like with any drug, your dosing's limited by the side effect profile of that drug, and diamorphine is no different. So you could give all the diamorphine in the world, but you would find yourself in a very painful situation and having to have a long conversation with someone more senior saying, why on earth did you do that? But generally speaking, 5 to 10 milligrams, IM or IV, remembering that's about half the potency of morphine. 2.5 to 5 milligrams as an epidural dose, and up to 500 micrograms as an intrathecal dose, although some papers would suggest that 300 is the point where you're going to see the most benefit against the most side effect. So we've talked about side effects here. What side effects could there possibly be with such a drug? Now, we all know that you can kick out a verbatim opiate side effect answer and move on with the exam. But all these opiates, remember, do have slightly different side effect profiles because different molecules can bind to other receptors lurking around the body, not just opiate receptors. They always can sneak along in, pethidine. They were planning for that to be like atropine. So, cardiovascular effects of diamorphine. It can reduce your systemic vascular resistance, causing mostly orthostatic hypotension. They're fine lying down. When you stand them up, they drop their blood pressure. In megadoses, you might see a bradycardia, and it can cause a degree of histamine release. From a respiratory perspective, it's going to diminish your depth of breathing and your rate of breathing, alongside impairing your cough reflex, which is great if you've got a really bad cough, but suboptimal if actually you're post-op and you need to cough. From a CNS perspective, it's a potent analgesic. It is the good stuff, and that's perhaps why people reach for it in slightly more questionable circumstances. I suppose one of the other dosing routes could be smoked and inhaled, but from a CNS perspective, drowsy patients, euphoric patients, sometimes they hallucinate, and if they're unfortunate, they might get a bit delirious. Interestingly, I'm going to put itching down as a CNS side effect. We'll go over that in a bit more detail later. From a GI perspective, it's going to drop your motility. It definitely causes nausea and vomiting. It would naturally be constipating, and it can cause sphincter of Oddi spasm. From a renal perspective or a genitourinary perspective, it's going to cause urinary retention, makes your bladder relax and hold on. So, we have chatted about the pharmacodynamics there, i.e. what the drug does to the patient. But what does the body do to the drug, you ask? So we need to think about the pharmacokinetics. Remember, this breaks down into absorption, distribution, metabolism, and elimination, and if you adhere to that structure, you probably won't go too far wrong. So, how good are we at absorbing diamorphine? Well, great oral absorption. It gets straight into that venous circulation of your GI tract. However, your liver is a busy little sausage, and there is extensive first pass metabolism, so it doesn't really make it past the liver if you just go and eat a load of opium. Well, diamorphine, we're being specific here, aren't we? Its distribution, so it's 40% protein bound, and has a volume of distribution of 350 litres. So we can infer from that it surely must be quite lipophilic. Or is it actually a drug that rapidly becomes a different drug once it's in your body, and therefore if you're just measuring diamorphine levels, you get a artificially low measurement? Who knows? Well, its pKa is 7.6, and it is 34% unionized at plasma pH. And we need to remember that fentanyl is about 9% unionized, and morphine, with its pKa of 8, is 23% unionized. So there's already a free fraction of this agent ready for action and available for lurking across these fatty membranes, getting where they need to go. Thinking about the metabolism of the drug, I can tell you that diamorphine is a prodrug. So the physical diamorphine molecule doesn't really do very much with opiate receptors, but in its diacetylized state, it is super duper lipophilic, so it really gets where it needs to go. And it's not reliant on a slow as poke liver metabolism mechanism to convert it to its functional molecule. It is converted by ester hydrolysis. So our dear friend pseudocholinesterase and red blood cell esterases, and a lot of other esterases, I'm sure, but those are the main ones to mention. And it converts diacetyl morphine into 6-O-acetyl morphine, and this is an active form of the drug. This 6-O-acetyl morphine is then converted again into morphine by removing that acetyl group, and then this morphine goes on to be mopped up by the liver, being glucuronidated into morphine 3 glucuronide and morphine 6 glucuronide, bearing in mind that those are active metabolites and they're renally cleared, and they can accumulate, if we're not careful, in people with knackered kidneys. How is diamorphine eliminated? So you will see about 50 to 60% in the urine as derivatives of morphine. There is a free fraction that is also passed, and just so we're all on the same page, morphine 6 glucuronide is the one that chiefly accumulates in renal failure and has the sedatey, dozy, you're going to stop breathing sort of effects. Last but not least, it's reversed with naloxone. Surprise. So that was a whistle-stop tour of diamorphine. Now, as you might expect, I got quite carried away reading about how opiates traverse our CNS space, i.e. epidural and intrathecal opiate administration. Now, this was clearly going to be far too big a topic to smash through, and I wanted to be specific to diamorphine. So I'm going to do an extra episode. It's going to come out probably on Monday, where we talk about how they came about sticking opiates in people's CSF spaces, how they work, how they move around the CSF space, and the things to consider when weighing up drug choice for intrathecal or epidural opiates. And we can have the excitement of thinking all about octanol water buffering coefficients. Oh, how exciting, guys! But actually, more importantly, having a deeper understanding of how these opiates shift around in the intrathecal space can really ground your understanding of why we choose what dose and what drug in what route. So it's going to be an exciting one. Don't miss it. Then after that, we're going to do remifentanil and look at the Minto TCI model. And then I hope we have done the opiates chapter and we can move on to maybe local anaesthesia, because that's an important anaesthetic-y type of thing. Anyway, cheers for listening, guys. Have a nice weekend. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.